Hello everyone, it's always a pleasure to be part of Osstem AIC community and share knowledge. Today I will talk about the implants in the aesthetic zone and what are some steps to take into consideration to avoid complications. There are different ways to treat a missing tooth in the anterior area, which vary from the partial removable prosthesis, Maryland or fixed prosthesis. However, these traditional methods are no longer used as patients want better aesthetic and functional results. So more and more implants are becoming the primary choice of the treatment. Nevertheless, it is important to have the right education and experience, which together with the right materials and qualified staff, allow us to avoid results like this and have good results stable over time, especially in the aesthetic area. Because today it's no longer acceptable to talk about survival of implants, if we lost the implant or not, if there is infection or not. Today the success in implantology means no bone resorption and a harmonic pink aesthetic around the implant. And for this it is important to know the whole process, what happens with the bone from the extraction to the placement of the implant, how the alveolar ridge resorbs, in what directions it happens, horizontal or vertical, and at what time we expect the most of the resorption. And the most important, can we do something to interfere with the process of the resorption? Can we slow it down or modify it in some ways? Studies from Araujo and others demonstrate that the reduction of the alveolar ridge is a consequence of a physiological principle. One of the most asked questions is whether an implant can prevent this physiological process of bone loss and so preserve the dimensions of the alveolar ridge. Different researchers concluded that the placement of an implant in fresh extraction site failed to prevent the physiological bone remodeling, which is genetically determined. This is a case of immediate loading and socket preservation using the one abutment, one time concept. Vertically, we have lost at least 2 mm of soft tissue and horizontally at least 2 mm of bone loss. The implant is stable, also the soft and the hard tissues, but we couldn't prevent the bone remodeling even by placing an immediate implant. We cannot totally eliminate the bone remodeling after tooth loss, but what we can make to decrease it and to prevent it. Some of the key factors for long-term success in implant placement are for sure the presence of the buccal plate, the primary implant stability, and of course the management of the hard and the soft tissue. The atraumatic extraction technique is a crucial component of the ridge preservation process. It can be time-consuming, but by following this technique, the quantity and the quality of the bone will be preserved, along with the gingival architecture. One of the most important instruments used in the atraumatic extraction technique is the periotome. These instruments are thinner and flatter than the conventional elevators, and when used properly, periotomes may remove a tooth or a retained root without damaging the alveolar wall or create trauma to the soft tissue. As we mentioned before, the primary implant stability is one of the key factors for the implant success, which is also influenced by many factors including the residual bone volume, the implant design, and the surgical technique we use to place the implant. While in healed sites, stability is obtained by intimate contact with the bone, in the post-extractive implant, bony defects are expected around the implant. In this case, the primary stability is only achieved by anchoring the implant in the apical bony region or by increasing the diameter of the implant. The implant design plays a major role to reach a good primary stability, and the taper implants were introduced to overcome the poor bone quality and quantity limitation, and also to allow an easy initial entry of the implant, especially in the post-extractive implants where we can easily make a wrong path. The implant surface characteristic and diameter also have been shown to influence the primary stability. The NH and the soy surface were introduced for a faster and a stronger bone formation, especially in the immediate or early loading protocols and in patients with poor bone quality. This is a clinical case in which we see the tooth before the extraction, the non-traumatic removal of the root, and then the placement of the post-extracted implant with immediate loading and at the same time the augmentation of the soft tissue. 3 months after the placement of the implant, impressions were taken and the final crown was delivered. In the last picture, we can see the beautiful pink aesthetic around the implant, which not only gives a harmonic architecture of the gingiva, but also a stable result over time. The primary stability in this case is achieved by using the apical part of the bone beyond the apex of the tooth, while in the posterior areas we often have problems because of the presence of anatomic limitations like the maxillary sinus or the mandibular nerve. In such cases, we seek primary stability by increasing the diameter of the implant. To maximize functional and aesthetic results, one of the cardinal rules in implantology is that the implant placement should be prosthetically driven. This means that the final restoration should be first planned and used as a guide for the 3D positioning of the dental implant. To have an ideal position of the implant, we should take into consideration first the mesiodistal position. The implant should be placed on the same axis that follows the mesial tooth. The apicocoronal position, how much the implant should be submerged in the bone. The labiopalatal position, which in case of the anterior area should be placed towards the palate, and the angle of the implant. I would like to spend a moment more explaining better the importance of the apicocoronal position based on the biological width. The biological width is the distance created from the gingiva to the implant platform. In the case of a thick biotype, where we have about 4 mm of soft tissue, if we place the implant at bone level, we would expect a marginal bone loss about 0.5 mm. In case of a thin biotype, where we have about 2 mm of gingiva, if we place the implant again at the same level, we will expect a bone resorption at least 2 mm. To have a good profile emergency of the final crown and to avoid the bone resorption, we need 4 mm from the gingival margin to the fixture. That's why in case of fine biotype, it is suggested to submerge the implant 2 mm. We will see now the hard tissues and what we should take into consideration while performing an implant placement. After a careful tooth extraction, the 3D socket evaluation is mandatory, because based on the integrity of the buccal plate, we will choose what kind of treatment to perform in each case. In 2007, Eliang and colleagues published a classification of the residual sockets, dividing them in 3 types. The type 1 refers to a whole socket, while in type 2 and 3 the socket is damaged. The difference is that in type 2 the soft tissue are still preserved, while in the third type soft and hard tissues are missing. To compensate the missing tissues, different treatments are proposed. In the type 1, where the socket is not damaged, the socket preservation with the proteinized bovine bone have demonstrated good clinical and radiographic outcomes. In the second type, except the socket preservation, a non-resorbable membrane is used to seal the socket because the buccal wall is missing. While in the third type, the gold standard is extraction, wait around 4 months, and then make a great bone regeneration. Let's see now a clinical case of an internal resorption. This is how the patient comes in our office. And after the X-ray examination, we can see the condition of tooth 22 and 23, a periapical infection of the lateral incisor, and an internal resorption of the canine. The treatment planning for the patient was extraction of the canine, socket preservation, and connective tissue graft from the palate, while in the lateral incisors, root canal treatment to give a second opportunity, and then wait for the healing. This is immediately after tooth extraction, the augmentation of the soft tissue, and the delivery of the provisional, a Maryland bridge which was prepared before the surgery. And of course, the treatment of the lateral was made before the surgery. Placing a post-extractive implant in this condition would have complicated the final aesthetic results, and the presence of the periapical infection doesn't also help. So that's why we decided for a treatment plan without post-extractive implants. Here are some steps during the virtual planning of the case, and then the placement of the implant using the one-guide kit. Here you are 3 months after the implant placement and the delivery of the definitive crown. Here is the X-ray control and the picture at the end of the treatment. And the final restoration. I will present now Ambra. She shows up at our office by saying, I want an appointment to place an implant here as soon as possible. We visited her, we took also pictures but lost some of them. And at the end was explained to the patient why we cannot place the implant, and because of the missing space, which could allow us not only to place the implant but also to have a beautiful aesthetic result. So we proposed to our patient a treatment plan that included first step with prosthetic orthodontics, and after that the implant placement with immediate loading. This is the result after 2 months of sectional orthodontics. And the radiograph after 2 months. And now we are ready to place the implant. Always check with an intraoperative radiograph the direction of the implant after the first drill, especially in areas with limited space. And at the last X-ray, we can see the implant placement and the provisional delivery. 3 months later, the definitive impression was taken, and here is the photo during the try-in. Always wait like 5 minutes to see if the soft tissue compression goes away. Otherwise, with a ceramic rubber, we can touch the area of the compression without the need to resend the work in the lab. 6 months after, we see the maturation of the soft tissue and the stability of the bone around the implant. Frontal photo and radiological examination 6 months later. And finally, the radiological examination after 1 year and a half. In the case of the laterals, where the mesiodistal space is limited, try to move the implant slightly distally, closer to the canine, which has a stronger and healthier periodontium. Last but not least, the soft tissue management. Almost every implant we place in the anterior area needs soft tissue augmentation, no matter what type of socket we have. Many studies support the role of keratinized tissue in preventing bone resorption around the implant, and a lack of it, or an amount less than 2 mm, would lead to an inevitable bone resorption. We have 2 ways to increase and to improve the quality of the soft tissue: the open and the closed technique. The most commonly used is the closed technique, using subepithelial connective tissue taken from the palate, while in the open technique, or the strip technique, improves not only the volume, the quantity, but also the quality of the keratinized tissue, and it is usually for extended areas. She is Elena. She comes in our office with a dancing lateral incisor. We can get a lot of information simply from an endoral X-ray. The tooth to be removed represents a short root, lack of periapical infection, and an easy extraction as the tooth presents mobility. All of these help us make the right treatment for Elena, which includes the extraction of the lateral incisor and the placement of an immediate implant with immediate loading. At the same time, the augmentation of the soft tissue, as we expect an inevitable physiological resorption that will lead to the contraction of the hard and the soft tissues. The lateral incisor was extracted, the alveolar spaces were filled with the proteinized bovine bone, and then the implant was placed. Here we briefly look at the procedure of taking tissue from the palate and fixing it to the buccal area to increase the amount of soft tissue around the implant. The close technique is used so that the trauma to the tissues around the implant it is as small as possible. First, it is important to remove the epithelium from the surface of the tissue and then make the incision to get the amount of the graft we need. Very careful what type of scalpel you use. The 50C is recommended because it has a small head and it is more delicate and traumatizes less the tissue. And it is important also to make a partial flap around the implant in order not to interrupt the vascularization of the flap. This is an intraoral photo at the end of the surgical procedure. The provisional tooth is not only not in contact with the antagonist, but it is at least 3 to 4 mm shorter, so that the trauma created during the mastication will be minimal. Occlusal photo of the provisional, showing the palatal direction of the implant, which is important for a screw-retained definitive crown. And the shape of the provisional should be ideal, as the tissue will heal around it. 4 months after the implant placement, impressions are taken and sent to the lab. A copy of the shape of the cervical part of the provisional has been taken, and the information was transferred with the impression in order not to have modification of the soft tissue. And here we are at the end at our patient rehabilitation. Radiographic examination 5 months after implant placement and immediately after final crown delivery. Here is the patient before and after the treatment. And 4 years after implant loading, we can see the stability over time of hard and soft tissues. To close this presentation, we can say that the implants in the anterior area represent a complex area that requires a good diagnosis and treatment plan that includes 1 to 2 extra surgeries for soft tissue augmentation, a prosthetically driven implant placement, and the right techniques and materials. And in conclusion, it takes a lot of time and patience both from the doctor and from the patient to succeed. This was a presentation for the day. You may find my research activity on ResearchGate or send me directly a mail for any question or information. Thank you, and see you in the future events with Osstem AIC.